Yesterday we looked at the more of the sort of the macro level in terms of policy agenda setting, policy formulation, and thinking about the influence of different kinds of actors at that level. Yeah, and the reason we're pitching that as the studying the macro level is because often those actors that are making decisions about what gets onto the agenda are quite powerful, they're quite high up in terms of the hierarchy. Not always, because as we said yesterday, sometimes unusual actors get onto the policy agenda setting process, so activist interests sometimes, or researchers. But generally we situate policy agenda setting and the study of policy documents and policy analysis generally at the kind of macro level of HPSR. So now we're moving into the meso level. And by the meso level, you'll remember that we're essentially talking about the mid-level, right? So the bridge between what happens kind of at the macrostructural perspective or level and the micro level of interactions in the health system. So we're going to do, this lecture is going to take us through, remind us what is the meso level, why is it important to health policy and systems research. We're going to briefly talk about key stakeholders at the meso level, and then we're going to mention some theories that are relevant. Okay, along this course we've been giving you a number of theories that you can go and research yourself, and you can see whether they're useful for your own work. We don't want to overwhelm you with this, okay? So we will be giving you quite a lot of theoretical inputs, but the main reason that I would like to convey, theory to you in this course overall is to remind yourselves that nothing you do is neutral. Absolutely nothing. Even if you say, I have no theory, I'm going to go out and look at practices and knowledge, etc., you are theoretically informed in terms of how you look at things, your ontology, what your reality is, your epistemology, the sources that you're going to use to get that knowledge, and your methodology, which is how you go about doing things. So it's always informed by broadly a research paradigm and more narrowly a theory. So just remember that, okay? Now the meso level, we said, is the crucial bridge between the macro and the micro. The macro is often thought of as more broadly the policy level, and the micro is thought of as the service delivery level. And this is just the little diagram from the reader, from the Lucy Gilson reader, that shows you kind of how those levels fit like onion skins in a diagram. But this is another way of looking at it in terms of understanding that the meso level is the intermediate level. It's the level of organization of care, of practice of care. But it doesn't just include what happens in the health system. It's also considering the social context, because social norms at the community level, at the regional level, at the national level are also, in a way, they're very influential in terms of how people behave in the system, okay? So this is the meso level because we think of social institutions, yeah? The education, the religion, gender dynamics, those are social institutions that have normative rules, they might have expectations around how people behave. And we cannot pretend that the health system is somehow divorced from the social system. Yeah, the health system and the way it operates in India is very much influenced by social norms outside of the health system. So it is our job as researchers to sometimes unpack those connections, which means you have to yourself take a step back from your own preconceptions, right? So if we moved all of you to another setting and we transplanted you to Indonesia and we asked you to look at the dynamics of care within the health system, you would notice all kinds of things that would not be familiar, that are based on hierarchies or the way people relate to each other or the way people group together, which is probably rooted in social norms in Indonesia, right? Which we would have to unpack. Okay, so meso-level health systems functions Usually we're thinking about the sort of the local level, the district health system. It's concerned, and we're really concerned with these functions of oversight, management, leadership, organization at that district level. So this is when we think about the functions that are happening at the meso level, this is organization of the health services. So you think about models of care. How is care being organized? What are the guidelines that dictate how people move through the system? How the health workforce, collaborates, or what is the division of labor? That's also a management function. We're also looking at the provision of health services and wider health promotion activities. But remember, this is not about the individual level interactions. This is about the level at which the sort of the broader rules that govern how the system is organized. It's also about coordination among local actors. So it's understanding the dynamics of organizational culture, how people relate to each other, the ways in which they also relate to members of the community, broadly speaking, okay? Not individually, not in the individual interaction. It's about things like managing resources. So managing the budget, managing the services, managing health workers. Everything that has to do with supervision and training is also the meso level, because it is about a collective attempt to say, this is the way we're going to ensure quality of performance in this set of health workers, okay? And it is also about adapting national policies and guidelines to local circumstances. So whenever you discuss this topic of policy implementation, usually it's at that meso service level, because you're not looking at policy implementation unless you said, what does this policy implementation have? How does it influence the relationship between the doctor and the patient? That's different. That becomes micro level. But generally, how are these guidelines being distributed? How are people taking them up? What do they mean for the service is meso level. Yeah? And it's also around systems that are put in place, information systems, but also monitoring systems, evaluation systems that are looking at setting targets, assessing quality, assessing performance. So why is the meso level important in health policy and systems research? It has a key role in translating policies into action. So just taking 3 examples, when we look at systems that have decentralized, that means they have, allocated decision-making, budgets, and other kinds of resources. They have shifted it down to lower levels so that there is autonomy at lower levels to make decisions. That is something that is very interesting from a meso level, because we want to understand how those decisions are to take place. How are they actually making a difference to the overall performance and responsiveness of the system? There is also issues of coordination and integration. So many health systems are fragmented, and we know that somebody who comes to the system who has, let's say, TB, but also has diabetes, how do we do a better job of serving them instead of them having to go this direction for the TB, waiting 4 hours, and then maybe if they're lucky they might be seen for their diabetes, right? So we're all interested to have better integrated person-centered systems. So a strong meso-level institution is about ensuring continuity of care, ensuring that seamless delivery across regions, across levels of facilities, maybe across types of providers. That's also a meso-level question. And then the third important issue in terms of health systems reforms are all those reforms that have to do with improving people's access and equity in terms of coverage of services. So those things that are related to making the services affordable, offering free healthcare, for whatever deliveries and so on, or understanding different kinds of incentives also for different providers. So this is looking at how do we influence, how do we improve health equity of the system by distributing resources and setting priorities at the meso level. Okay. Now, who are the stakeholders we're talking about? When we're doing research at the meso level, who are we speaking to really? So there's a number of key stakeholders. We're thinking about government agencies. So we said that the district health management team is certainly in many, many low and middle income countries, it is really the heart of the meso level, and it plays a critical role in implementing national policies. We're also looking at healthcare institutions, but at a certain level, okay? So we're not really going all the way down to primary care, but we might be looking at hospitals. I mean, we could be looking at primary care, but we're looking at the kind of management level of primary care. Often there are some very interesting studies, comparative studies of looking at hospitals and how hospitals are implementing, for example, guidelines to improve, let's say, neonatal care, okay, to put in new, improve clinic safety and efficiency, and understanding the hospital is the unit of analysis, okay? Not the individual provider, but the hospital performance, because the idea is that there are lots of components within the hospital at meso level that ultimately influence the quality of care that's provided in that hospital. And you might have the same if you're looking at, a community, whatever they're called. They're called differently in every country, but community health center and so on. But remember that the unit of analysis is the institution rather than the person. We're also thinking about community organizations, because we assume that their involvement is going to support health systems goals. It's going to improve efficiency and innovation in healthcare. What do I mean by a community organization here, do you think? NGOs, maybe, yeah. CBOs, maybe they are some CBOs that work in health and social development, or they work on HIV. Okay, but they're working on a specific area of health, or on mental health, or on violence, and they are, sometimes they're linked to the health system directly, and there's an attempt, for example, many African countries, a lot of health services are run through partnership with faith-based, so church-based organizations, or private organizations, because the public sector cannot cope up on its own. But in other cases, they're actually running parallel services, because they have together, hopefully, with the Ministry of Health, they've decided that they're going to take care of, a specific form of specialist counseling or something like that. So CBOs are important, community organizations. And then, of course, there's the private sector, which is also a key stakeholder at the meso level and has a significant role in healthcare in many countries now. India, we started to talk about the private healthcare in India many, many years ago, more than 20 years ago. And it was at that time maybe only starting to emerge as an issue in many African countries. But now if you look, for example, at Kenya or Nigeria, they similarly have a huge private sector, which caters to a large number of people. So it's very important to understand the role of the private sector, the relationships, and so on, as you are doing in your topic. Okay, so let's go through each one of these separately. Let's look at the district level. So in the context of health policy and systems research, so district level program implementation falls within the meso level of analysis. The role is really, at the district level, we're translating policies into action. We're trying to ensure system-wide coherence and facilitating coordination, which happens across and within the organization and the administrative structures, but also in health departments, in district health offices, and particular service delivery units. So within the district health system, you're going to have a maternal health unit, or the TB program, or the SRH, and you might have a number of units. And those units and how they interact is also very interesting from a meso level. The key actors we're looking at are the district health offices. These are not so much actors, but structures. local governance structures, health facility management, NGOs and CBOs we mentioned, as well as professional associations. So professional associations, medical associations are also relevant here. So this is an example of a paper which is comparing district level decision making and how it's shaped within decentralized contexts. So 3 African countries, I'm just showing you maps of 2, but Malawi, Uganda and Ghana had important reforms to decentralize health systems during the 2000s. And this paper really looks at what's kind of going on in terms of decision making. And it compares the 3 countries because the actual location of the district health management team is slightly different if you look at the organogram, right? So the argument here is, of course, that the district health system is the entry point for the implementation, but also the scale-up of health policies and systems intervention in many low and middle income countries. It usually has a variety of primary care centers and hospitals that are managed by the district health management team. And in a decentralized context, I'm wondering if it's something to do with me. No. In a decentralized context, your decision making is transferred from the national to the district level. And those DHMTs play a really important role about making decisions about which health areas, which interventions to prioritize. And they're actually the ones who are adapting, they're contextualizing, they're implementing policies that are developed at the national level, but they've got to make them work for the district. So it's very interesting to look, first of all, into questions of whether policies are really decentralized, because sometimes when you interview people at the district level, they'll say, look, our hands are tied on this budget. It's the provincial that holds it. In some cases you'll have the opposite, which is the power is so devolved that they're actually able to develop a policy in quite a different way, which is much more suited to the context of their district. So I've been in both kinds of settings. Okay, so now we're thinking about health facilities as another entry point for meso level work. And here we're looking at healthcare institutions. So this is the level where the health program is managed and executed and where the services are delivered. And we're particularly interested in the roles of management, okay? There was about 10 years ago, there was a lot of interest in mid-level managers because they said that they were not given enough attention. And this is the sort of in-between cadre. We're looking at leadership, as I said, service provision, things like quality control, monitoring, community engagement. And again, you have different kinds of actors. These are just examples: primary healthcare centers, community health centers, district hospitals, TB units, microscopy centers, private clinics, etc., and community health worker programs. So I just want to show you a nice example from a paper which is about improving facility-based care. And what I like about this paper is it really adopts a meso-level approach to understanding what is required to improve care at the meso level. Yeah? And we're talking about, this was in the wake of a big Lancet editorial, which was about high quality health systems. So how do we improve quality in the performance of health systems? That seems to be still a major, major issue. So this is a group that is based in Kenya, and they've done some really excellent work, also comparative work across hospitals to understand what is really at the meso level, the resource issues, but also the soft issues, the organizational culture that promotes and enables an environment whereby quality improvement initiatives can flourish. Yeah? So here they're talking about improving facility level care. They call this the quality and the safety cube. In many LMIC, the quality, safety, and thus outcomes of facility-based care are undermined by challenges in 3 resources. And now listen carefully to what they mean by the resource areas. So inadequate physical or material resources. So that is your basic structures, your technology, your equipment, your machines, whatever. Deficits in work capacity and capability. Here we go, come up again with your original words, but capacity and capability relates here to the health workforce in place. So do we have enough health workers in place? Do we have the right mix of health workers in place? And do they know what they're supposed to do? And are they able? Sometimes they know what they're meant to do, but they're not able to do it because of the chain of command is compromised or the resources aren't there. So basically, they're looking at the interactions between the first area, which is inadequate physical or material, the second, which is deficits in the health workforce, and the third, which is poor team and organizational relationships. So they bring in this software component. As a result, local facilities tend to operate within the red zone of the cube. So the argument here is that we need to be mindful of the interactions across these three resource areas in order to move forward with quality improvement strategies. And you see on the right-hand side, on the top right, you see, oops. You see the issue of goal alignment, leadership for change, empowering key actors, responsive planning, and learning. So those are 5 areas where you would hope to achieve in terms of your quality initiatives. So the quote from this paper that I like is, when considering change, we must be aware of the formal and informal rules that guide behavior. This can mean thinking about power in its many forms, and which individuals or group might exercise their influence over an intervention, and how an intervention might require practices that have become deeply established over time to change. Okay, so their interest is, their point really is to say that even if you have the workforce in place, even if you have the material equipment in place, sometimes it's very, very difficult to change, to ask people to do things differently than what they're used to doing, because the organizational culture is very rigid. Okay? All right, that's an example for thinking about healthcare organizations. And now we're thinking about community organizations. So we said communities are part of the Meso level, as they act as an intermediary between macro and micro. Their role is often as active associations or participations in shaping or implementing health interventions. And here we're talking about both local governing bodies, such as the panchayats, municipal bodies, district level committees, but also CBOs, self-help groups, local health committees, and we might be talking about traditional and informal health systems at the Meso level as well, because they also have associations, right? Your association of RMPs or your associations or networks of traditional healers. So these are just, again, what we're referring to is specific networks, groups, and organizations within the community. We talk about them in terms of the resources they offer, the support they might offer to access healthcare facilities, but also in terms of staffing, because if you think about many lay health worker or community health worker programs, they draw actively on members from the community. So there are a community health worker program is a direct bridge between the micro and the macro often, in terms of the level. But we're also talking about actual organizations and what they might constitute. So looking at CBOs, one very important example of the role of CBOs in supporting the formal health system was throughout the HIV pandemic, particularly in the early years, when CBOs and community-based and community-led HIV service delivery was very prominent, particularly in Southern Africa. And this is from a report published actually very recently 2025, which is taking a historical look at what role they had and comparatively. I think this is just in Eastern and Southern Africa, actually. But it's full of case studies which talk about, this important meso-level influence. And here we're referring to communities of people who are living with or have been affected by HIV and how they get involved in both supporting and delivering HIV-related services, encouraging or mobilizing the community, creating demand, and also increasing legal literacy. Sometimes it's a different function. It's around social inclusion, social justice, social protection, or making sure that the rights of people from marginalized groups are put forward. So this is a meso-level example of a community-based organization. The fourth area we mentioned is the private sector, which operates at the meso-level because it's influencing performance, access to care, and policy implementation, which makes it a crucial actor. It plays a significant role, obviously, in healthcare delivery, especially in mixed health systems. And there's a number of actors, depending on the country that you're in, that belong to this sector. So it's the for-profit providers, it's the not-for-profit organizations, but that are still private, charitable, faith-based, but it's also the big range of informal providers that you have, which can be, the licensing and the legitimacy is really variable. So what I thought was interesting is that this article is from, let me see, I think this is fairly recent, if I'm not mistaken. Yeah, January, 24th of January this year, that this topic never goes away, ever. So this is a topic I worked on 25 years ago in India. The importance of the private sector in health systems in LMIC is strongly accepted and understood in health policy and systems research. Yet there continues to be a gap in understanding how private healthcare sector actors engage in policy processes. So for those of you interested in this is still a really important research topic. And this is just, I think it's one of the vociferous proponents of regulating and standardizing the role of private care actors, Abhay Shukla. Is that right? Abhay Shukla? Yeah, I think it is. And he's here, this is just a cutting from the media, from the Hindu, saying that, calling for regulation and standardization of private healthcare. So this is a huge topic, the meso-level role of private healthcare, their influence, etc., and how they influence the policy process. Okay, now what are the big challenges? We talked about the areas, we talked about different kinds of health reforms where the meso-level is very critical because the district is where everything's happening, but there's also challenges. So fragmentation of services, often there's coordination gaps between different levels of government, and this is something of interest as a meso-level topic. There are power dynamics in bureaucracy, so decision-making is often hierarchical and slow, and better understanding why things move forward at different paces is important. We're going to be looking at that a bit later this morning. And then the issues of limited data availability, so the weak health information systems at the meso-level, which are hindering effective or optimal translation of policies. Now turning to how we actually strengthen governance at the meso-level from a health policy and systems research point of view. These are also things that are pertinent, okay? So your training programs for your digitalization of ASHAs or for your integration of CHOs. Capacity building and training is happening at the meso-level. Fostering collaborative networks across groups that normally don't collaborate. So government, private sector, civil society. How are you going to promote better trust, better collaboration? Enhancing data systems for decision making. So this is a relevant topic regardless of digitalization, but becomes even more important. You can't jump forward to digitalization if your basic paper system isn't great, right? Good. Remember, these key takeaways before we move into the next topic. So the meso-level plays a crucial role in translating policies into action. Effective governance, coordination, and evidence use can be used to improve health systems outcomes at this level. And strengthening meso-level institutions is really essential for this idea of health systems resilience, which means that the system is better able to cope up with shocks. And by shocks, we can mean a variety of things. We can mean an environmental shock, we can mean a pandemic or an epidemic, or we can mean another type of shock whereby you have mini shocks. Strikers go, health workers go on strike. How are you going to handle that situation? Okay, so now we're going to move to theories that are relevant to health policy and systems research at the meso level. And now you're going to see a long list of theories. Please do not get intimidated, okay? What I want to say to you is that theories are, remember from your conceptual framework, essentially they are, they all started with a conceptual framework because they tried to explain phenomena, social phenomena, right? And of course they developed further and further, and they did some research, and they came up with ideas about what shapes behavior, what shapes processes, what shapes collective thinking. And so what you're going to see reflected is the influence of different kinds of paradigms, research paradigms, different kinds of theoretical positions, sometimes political positions, in terms of what they mean for health policy and systems research. So I'm not going to go into all of these, okay? Solomon very kindly put this long list together, but I think it's interesting to browse through them. What we're doing is we're giving you a very, very, very brief, and I have to say probably a bit dumbed down synopsis of what the key idea is and why this is important for the meso level, okay? So just picking up on some of these: policy implementation framework, street level bureaucracy theory. So the idea of street level bureaucrats is something Solomon already spoke about, which is that often it is people at the street level, at the lower levels of the system, that are actually doing a lot of the adaptive responses. So I mentioned to you the example from South Africa that we worked on, which was decentralized care for people with DRTB. There was a lot of street level bureaucracy in the sense that the nurses and even the community health workers were coming up with strategies to make the policy work, which is that they would take, they would figure out referrals. They formed WhatsApp groups to communicate with each other. They, stepped out of their own comfort zone, really, in order to make sure that certain patients were followed up. So those are all small mechanisms which support implementation of a policy, but are often not even acknowledged or not seen. And that has to do a lot with this notion of discretionary power. Yeah, discretionary power means even if I am not really supposed to do this, on paper my role is a nurse or a community lay worker, I'm not really meant to make this referral or make this phone call, but it's my discretionary power. There's a certain amount of wiggle room that people give or take in order to enable something to happen in the system. And you will all understand what I mean, especially in this context. And it has a lot to do with social norms outside the health system. So I'm allowed to make that call to somebody higher up in the system because he happens to be my uncle, yeah? Or there is something else which is informed by some kind of social connection. Often it's that. Or there is a kind of agreement that takes place within a group of health workers who are left to fend for themselves, that we can do these things. And there's a tacit agreement. So a lot of interesting work in this area is around tacit knowledge, implicit, which allows things to happen in the way they do that have nothing to do with official guidelines. So there's very interesting work in India on bureaucracy within maternal, I'll have to find that paper, I think it's called Performing Out. And it's about the gap between what people do to perform according to program targets and then what actually happens on the labor wards. Okay, so another example is complex adaptive systems. There's a kind of body of theory around understanding the system as complex. So they use a number of different terms to look at things like causal loops, pathway dependence, interest hubs, and so on. So they borrow terms that are actually normally associated with the natural sciences, because where does systems theory come from? It comes from computer science or physics, right? And they're applying that from the natural sciences to the health system. So many of the terms are the same, but they're trying to think about elements within the system as acting in the same way as you would find in a natural phenomenon. Okay? Principal agent theory is about is classifying actors at the meso level as principles and agents. So it's a bit about the structure agency argument. Yeah, there's certain people who are the holders or the guardians of the principles, and there's others who are doing the implementation, and they're known as the agents. Okay? So as I said, do not worry about this list. Yeah? All I want you to take away from this, which is very, very, very important, is that many people have theorized about behavior in the health system. That's the most important takeaway message, is that often the way we study is we kind of have one mindset. This is the way we do things. And then this sort of suddenly opens your mind because you think, oh, maybe I could look at it through a different perspective, through a different paradigm. Another long list. Okay, so there's lots of theories. Community of practice is also interesting. It's this idea that within a health setting, there is a movement. It's also known as mind lines, which means that health professionals will form a community of understanding about this is the way we do things here. And you'll often hear that this is the way we do things around here. Fine new guidelines come and go, all very nice, but this is the system that we have established for ourselves. And the community of practice can become so strong and so resistant to change that it is sometimes counterproductive in terms of moving policy forward. But it's important to understand why these communities of practice are there in the first place. And often they have to do not just with power or influence, but because there is an established way that people have found to work, which somehow works within their setting. Yeah? Okay, so we're just going to focus on 3 theoretical concepts, because I think going through the whole list will just kill you, right? So the first one is, and I'm going to spend more time on this because this is a bigger concept, is theories and the understanding of what exactly do I mean by organizational culture. We all have an understanding, more or less, of what culture is, but what's interesting is that most of us, especially if you trained in anthropology, tend to think that culture is somehow down there. It's the people, cultural beliefs, misconceptions, myths, stereotypes. Yeah? But there's culture everywhere. There's culture at every single level. So to broaden your mind and say that there is a culture of working within WHO, there is a culture of working in this university, there is a culture of working within your health management teams, is interesting, right? Because you suddenly apply the same rules or the same concepts, rituals, symbols, beliefs, perceptions, misconceptions, everything that you learned and you thought applied for this indigenous group. You suddenly apply it to macro level actors in WHO and you say, what are the rituals of asserting my authority in a high level organization? Okay, or in a hospital ward. And this is why, for me, it was very important to show you that picture. You know, that picture of saying, here's a group of lady health workers in Bangladesh, and I kept saying to you, tell me what you see, but you were already interpreting something about the culture, because you were saying, okay, white coat means authority, means doctor, bag means equipment, okay? Sitting on the floor means they're at a lower level. Why are they at a lower level? Because they're in a female-dominated society. So you're applying your rules of understanding culture to a different setting. And I want you to be able to do that at every single level. Okay, organizational culture. So organizational culture generally refers to the set of values, beliefs, attitudes, systems, and rules that outline and influence. Now, we're going to say employee behavior within an organization, because the original organizational culture theory was developed in the 1980s and was used to understand, employee and employer behavior in corporate sector. That's where this comes from. It comes from workplace, understanding workplace dynamics. Yeah? But you can think about employee behavior at the meso level. You can think about the culture within health systems and how it influences people's attitudes, etc. within that. It really plays a crucial role in shaping how the program is being implemented, how it's being adapted, and how it's being sustained at both the district and the facility level. So how does organizational culture influence behavior? It's provider norms, but also their practices in decision-making, in coordination, in frontline service delivery, but also in engaging with stakeholders. Okay? And we're going to give you an exercise after, which I hope will be fun, which is we're going to give you an excerpt from a day in the life of a manager, mid-level manager in South Africa. And I'm going to ask you to analyze and tell me what you see in terms of where ideas about organizational culture and power and so on are reflected. Okay? So thinking about organizational culture in district health systems, this is kind of what we're looking at. The values and the norms. What are the shared beliefs about how to deliver healthcare? What about equity and responsiveness? Okay? Because the way in which providers act with each other, managers act with providers, but also providers act and interface with the public is shaped by the culture. Yeah? Usually when you go into health facilities, certainly in contexts where I'm familiar, somewhere you'll find in the manager's office there'll be codes of conduct or something that looks very nice, which is, you must be friendly and you must be this and you must be that. So somewhere there is some kind of emphasis on certain values that this facility holds. But the extent to which those values are actually in practice or imbued is a different question, right? The other area is leadership and decision making. So is it hierarchical leadership? Is it directive or is it collaborative? Is it participatory? What is the approach to leadership and governance? The third is around change, innovation and adaptability. How well are district health teams embracing new policies, technologies, and practices? The things on the top actually influence a lot of this, yeah? And the other is around accountability and transparency. So how do you make the health system, the district health system, accountable? How do you hold it accountable to the citizens that are using it? What are the mechanisms through which you do that? And that is also an issue of values and how you translate them in practice. So these are dimensions of organizational culture. So these are a list, again, thank you, Solomon, for putting this all together, a list of organizational practices that shape implementation. And these are different things that are used as carrot or stick, right? The idea of the carrot or stick is the idea of the reward versus the punishment that are used in almost virtually any system. It's not only health systems, education systems, workplaces, etc. But these are different kinds of tools that are used at the meso level to shape organizational culture. So usually there is something around the hierarchy and the bureaucracy. How rigid or how flexible is that hierarchy, especially when it comes to decision making? What influences communication and coordination? Are there different formats? Okay, do they have regular staff meetings? Do you give the nurses a chance to discuss difficult cases? Or where is that happening? Yeah. Are you using different platforms? Are you using formal platforms, which everybody can see? Or is there an informal WhatsApp group that people are communicating and using? All right. Then there's the whole area of performance management and incentives. So through which ways do you monitor the performance of people within your team? And how, and I think one of you had those questions as one of your research questions, how do different types of incentives influence performance, right? So that's also about different kinds of supervision, you know, top-down supervision versus supportive supervision, et cetera, et cetera. And then there are also issues around how are community health workers, how are different members of the community, how do they become part of the organization? So that's your topic, essentially, yeah? The integration of a new type of community health officer. This is also an area that is studied, which is resistance to change and power dynamics, and how certain kinds of power structures will enhance or enable change. And there's a whole field of study called change management versus, you know, what are the blockages? Okay, so let's look at managerial practices. So these are some examples of papers, which are very good examples of HPSR at the meso level, focusing on organizational culture. So this paper is on constraints to implementing an equity-promoting staff allocation policy, understanding mid-level managers and nurses' perspective affecting implementation. So they put in a strategy mid-level, meso level, to try to be more fair and just about allocating staff. And for some reason it didn't work. So they're looking into that. Another paper that is an interesting paper, which is where we're going to draw the extract for you from, is a paper around everyday politics and the leadership of health policy implementation. So this is really looking at, instead of trying to think about policies as papers, guidelines, things, just look at the politics of everyday running a clinic. Because there's politics left, right, and center. Politics is not just up here at the level of political parties. Politics is everywhere. So another issue in health policy for most health policy researchers is to recognize that politics permeates, yeah? Okay, another place that is very interesting to study organizational culture is what happens in the workplace. So this is a scoping review, I think an interpretive review, influence of organizational culture on the implementation of health sector reforms in low and middle income countries. Now you see the same name popping up everywhere, Lucy Gilson. This is very much her field, okay? But we also did a small paper not so long ago where we were looking at mask wearing practices for TB IPC. And this became very pertinent. Of course, during COVID, everybody started wearing masks, so it was a different question. But this study was initiated pre-COVID. So we were trying to understand, because people had pitched it as a micro-level issue. Are they wearing their masks or not? And woe to them. Why aren't these health workers wearing their masks? So it's often pitched as a behavioral non-compliance, right? It's a micro-level issue. And instead we said, it's not micro-level, it's organizational. There's something about the culture of the place in terms of management, leadership, setting role models, incentivizing this kind of behavior around safety, and also promoting the idea that it's not just about patient safety, it's also about health worker safety, that is influencing, you know, whether people are conforming to this idea of wearing masks or not. So we did a small paper in the Western Cape on looking at the data from the Western Cape, which is a region in South Africa that is known to be slightly more advanced in terms of many health reforms, including in TB and HIV. This is another paper which I personally haven't looked at, but this is another example of looking at organizational culture at the workplace. And this is about gaps in frontline workers, clients, and health financing policy implementation gaps. We charge them, otherwise we cannot run the hospital. Okay, so this is in the context of a country which is supposed to have no fee for service, but ends up implementing some kind of informal fee for service because there's recognition that this, you know, this whole policy would lead to a a situation of financial, complete collapse of these hospitals. So this is another famous Ghanaian health policy and systems researcher. Okay, now moving to the community, we also said that we're interested in understanding organizational culture from a community point of view. So here we're looking at norms, how communities participate. We're looking at power dynamics and decision-making at the community level. And we're looking at the influence of those community-level cultural factors and how they impact on what happens in the health system. So an example of this is exploring stigma and social norms in women's abortion experiences and their expectations of care. So this is understanding how social norms outside the clinic permeate inside and affect the way in which providers behave with their clients. Yeah, so it's looking at community norms intersecting with what happens in the workplace. And this is another interesting paper from India by Sumit Kane, who works in Australia. How social norms and values shape household healthcare expenditures and resource allocation. Okay. The third area is, we talked about workplace culture, we talked about community norms, now we're talking about provider norms, okay? And how organizational culture can impact on provider norms. So there's a nice paper on dual practice of public hospital physicians. This is a common thing, moonlighting or whatever you want to call it, where people work in both the private and the public sector, and understanding the motives around that, understanding how people do that in a way that they can live with from a moral point of view. Impacts of corporatization of healthcare on medical practice and professionals in Maharashtra. So it's basically saying that the provider norms, in other words, the normative belief system under which providers work, instead of just saying they're bad, you know, or they're not complying with guidelines, we need to situate them. We need to understand what is the context within which they operate, right? Another very nice paper is on a relational view of public health policy implementation in urban India, and it's looking at why is it that so many doctors didn't, at a certain period, comply with HIV testing guidelines. And it was essentially portraying a very sympathetic side of these providers, saying that they were disempowered. And it explains these different organizational contexts which led to non-adherence to guidelines. It's a very long paper, but it's a very good paper. Okay, another theory, organizational culture for me was important because I think it's a very important term and it's widely used and you should be familiar. But we're going to mention two more theories before we close this session, which is the issue of this notion of street level bureaucracy. And I mentioned already, this is kind of the little man or the little woman, so-called, that's doing their thing to make policies work. So policy implementation, this theory argues, comes down to the frontline people who implement it. So to understand public policy, it's the street level bureaucrat whose behavior needs to be examined. And it's a theory that goes back to the 80s. I don't think it was even used in healthcare. It was used in a completely different field. But people, I don't remember who first used it. Again, probably our friend Lucy Gilson. And the idea is that the policy-making role of a street-level bureaucrat is built on two assumptions. One is that they have a relatively high degree of discretion. And that means that they do have that capacity, even if it's not on paper, to make decisions according to the moment. Okay, this patient arrives. Okay, we see that they're really badly off. Okay, I'm going to make a quick call, or I'm going to extend some funds temporarily, etc. They're constantly wielding whatever resources and whatever small power they have, but they're actually making things happen. And they have relative autonomy from an organizational authority, because if they were constantly under surveillance, they probably couldn't do these things. So there is this paper, We Are Bitter But We Are Satisfied, Nurses as Street-Level Bureaucrats in South Africa. So I think this paper essentially is saying that on the whole, on paper, their position isn't great. Okay, they're underpaid, overburdened, dissatisfied with their work, but dissatisfied to an extent with their positions, but in principle, they themselves recognize that they have small discretionary power that they use. Okay. Okay, the last thing we're going to look at is social network theory. Now, obviously, social networks is a huge body of theory, but essentially the principle is that social networks matter. The connections we have to people, horizontal and vertical, are very, very important to behavior. So networks of relationships influence policy diffusion and knowledge exchange. So network theory has been used, understanding social networks has been used in health policy and systems work and is very important at the meso level. What we can do with social network analysis is to generate, and you're going to do that in some small way later, an actor level analysis of health systems. So in other words, you're going to look at who are the important actors for your topic and how are they connected, yeah? And it can help you decide. I mean, imagine you're probably only going to identify maybe 5, 10 at most. But imagine you kept asking, okay, so how is this connected and how is so-and-so? You would end up with 20 or so. And then you would start to realize which, it's like, all roads lead to Rome. Which people keep getting mentioned? Who are the main kind of hubs of influence? It's arguing that the position of an actor in a network determines their capacity to both access but also diffuse, which means to transmit knowledge and information. So they're controlling the flow of information, not just information, resources, right? So there's a nice paper in Health Policy and Planning, which is about how to do or not to do a social network analysis in health policy and systems research. But here is, again, an Indian example, which I liked very much because we don't tend to think of informal healthcare providers as having social networks, nor that they might have an influence on policy. But it is suggesting that we have to take better account of these networks. And if we want to leverage the potential role of informal healthcare providers, which makes a lot of sense in areas where there's not much else, right? Okay, so Solomon has again kindly provided you with lots of references. We're going to stop for now, and then we'll have a short break before we move into the next topic.